So today is going to be chapter 8. It is over pathophysiology. At the advanced level, the pathophysiology knowledge does go up a little bit. It doesn't go too crazy, but there is some degree of like biochemistry, and that's a lot of what we'll talk about in here, along with some of the other things that you probably will recall from your EMT class. Hopefully you'll recall it because it's things like shock, and then a little bit of anatomy stuff. So we are going to be talking about pathophysiology of the major systems. If you're unfamiliar with the word pathophysiology, if you break it down, the path or patho part of it has to do with disease, and physio is the physiological processes of your body. So it's disease processes. That's what we're studying when we look at pathophysiology. And with that, it also, we consider how does it impair functioning at the small scale, the large scale. There's a lot of layers to it. So there are some adaptations in cells and tissues that are, they're all different. Some are far less problematic than others, but it gives you an idea of how cells can change and then where things like cancer come from because it's cell mutations. So some of the specific types of adaptations that your tissues will go through is atrophy. Atrophy is loss of muscle mass. It's very commonly seen in people that are like wheelchair bound or bed bound. That don't really use their leg muscles, also with like, paraplegics and quadriplegics. Hypertrophy is when the number of cells doesn't go up, it's the size of the cell that grows up, or that grows. So when we think about hypertrophy, a lot of people think that hypertrophy is a good thing. For certain groups of people, say like bodybuilders, maybe hypertrophy is a plus, but when we consider the heart, we don't want the heart to get bigger muscle or bigger tissue cells. We want it to be stronger, and that actually looks like better blood flow rather than larger muscle mass. Hypertrophy in the heart is not a good thing. Peripherally, if you're using it for physical achievement of like athletics and whatnot, it's pretty okay. Hyperplasia is when you have an increase in the number of cells, and that can be problematic because when we're talking about numbers, we're talking about things that are usually multiplying without really any intervention. This can be kind of where cancer can take off or something similar to it because these cells just grow and they grow rapidly. Dysplasia and metaplasia are interesting. So metaplasia is when a cell is replaced by another same type of cell or a mature cell. And then dysplasia is when you have a mature cell that actually changes its shape. So they both have to do with the cell and to some extent mature cells. Dysplasia is when the mature cell changes shape. Metaplasia is when that cell is replaced by a mature cell, which is a good thing. We do like that to an extent, but again, you can appreciate where that can become problematic if it continues to replace it without it needing to actually do that. So fluids at the advanced level are one of the big things that they do. It's a very valuable skill to have, and each department is going to have kind of different protocols for what they let advanced EMTs do, as in like maybe how much or the type of fluid. But it totally depends on the patient type, pediatrics, elderly patients. There's all things that you have to consider when you're looking at fluids. But for some little foundation of how fluid imbalances and fluid exchange works, so we are always operating, our body is always shooting to be in a state of homeostasis. And homeostasis is never just a flat line. We always hover above or below, and we kind of go around or above and below that line. That's homeostasis. Your blood pressure is going to go up, it's going to go down, it's going to go up, it's going to go down, but they're usually very, very minor changes. That is homeostasis. It's just trying to make sure that we are executing our bodily functions and meeting our metabolic needs. And this is going to come up a bit when we get into the hypovolemia shock, hemorrhagic and non-hemorrhagic, but specifically fluids. In this case, we're just talking about the big picture. So there are a few things that can affect the fluid imbalance: size, age, underlying medical conditions. This is what I was talking about when I said that each patient is going to be a little different. Not everybody is eligible for fluids, let alone a ton of fluids. And then you also have to consider, like, how is the body getting rid of it? Does the patient have normal urinary output? Do they have urinary retention? Those are all things you need to consider with fluids. This is edema, and in this particular case, it's quite obvious that this is some pretty intense and gross swelling, as in like it's taking up the totality of her ankle and foot. This can't be comfortable with these shoes on because this pressure underneath the skin can get to be really painful and uncomfortable. Sometimes what can happen is if the fluid underneath of the skin, like the pedal edema, gets so bad that it actually forces its way out of the tissues, and it becomes what we call weeping edema, which is quite interesting and kind of alarming sometimes, but that just tells you how bad the edema is. We see this in patients all the time. It's not just exclusive to, like elderly people or pregnant patients. Medications can cause this and a ton of other things. So these two words right here, you're going to hear a lot of these. So isotonic, there's three things, and we'll go over the others here in a minute, around this concept that you need to understand. Isotonic, hypertonic, and hypotonic. Isotonic in this case, it is a neutral solution. Fluid is going to shift in and out of it. The solute and the solvent are at a great ratio, so it's a very stable fluid. In this case, we're usually talking about normal saline. If you have an isotonic fluid deficit, you have a decrease in your extracellular fluid with proportionate losses of sodium and water. So if we break that down, the extracellular fluid, so if you want to think about it as like maybe the fluid surrounding like your red blood cells, that fluid is going down, and that fluid is going down at an even ratio with the amount of salt that you're losing. So with an isotonic fluid deficit, you're losing water and salt at the amount that they work together with, if that makes sense. I couldn't tell you the exact numbers for how much it takes to create an isotonic solution with salt, but the key is that you have the shared drop of your sodium and water levels. Now with an isotonic fluid excess, you have just increase in that extracellular fluid. It's excess. It's not always a bad thing, but in certain patients it can be. But the key here, again, both of these are taking place in the extracellular fluid. That is very important because if you think about osmosis and other things that we'll talk about here soon, there's a big difference between extracellular fluid and intracellular fluid. In this case, we're talking about extracellular. So for a little bit of electrolyte imbalances, don't be surprised if you don't encounter these numbers very often, unless you work in a hospital as like an ER tech maybe, or like some kind of facility where you actually monitor blood work. Pre-hospital, we don't really do that, but it is very helpful for us to at least have an idea of it because we do frequently transfer patients out of like clinics or dialysis clinics and things like that. So just being able to have some idea of these numbers is really going to be helpful. When we refer to sodium, we're referring to this base right here, which is NATR or nater or natter. That is the Latin, I believe it's Latin, Latin root for sodium. Hyper obviously means high, hypo means low, ea means pertaining to. So these are conditions that are pertaining to sodium levels in your blood. Sodium, one of the most important things that we have in our body, where salt goes, water goes. They will follow each other. They like to be with each other. That's, again, what creates our isotonic solution and keeps our blood pH, or is part of what keeps our blood pH neutral. And the levels here might seem like there's not a lot of give, and there's really not. The 135 to 145 milliequivalents per liter for sodium levels is not a ton of wiggle room. And the big thing that you run into when it comes to problems with sodium levels is going to be like cardiac problems and seizures is really kind of what we worry about. Obviously, it's dangerous in the big picture, but for me personally, I'm thinking primarily about things like cardiac effects and then like seizure or neurological problems. Potassium is a very interesting one as well. I'll be honest with you, I wasn't super familiar with potassium when I was in EMT school. It wasn't until I went to paramedic school that I realized just how important potassium is and how appreciating its role in your body is really going to help actually with some of your patients, or at least understanding what might be going on with them. Because potassium, when we refer to potassium, we use this Kal, kale. That's the Latin root for potassium. So hypo and hyper, obviously low and high. Your normal serum levels are going to be 3.5 to 5. I've also seen some literature that says 5.5, but your textbook is going to say 3.5 to 5 milliequivalents per liter. Potassium is one of those ones as well that you don't really have that much give as far as your levels go before things start really going downhill. People that have hyperkalemia or high potassium levels are frequently subject to cardiac arrest, something that we see a lot of. Diabetics see that a lot as well. Hypokalemia, not as much, but hyperkalemia is something that you'll hear about pre-hospital quite a bit. And especially if you're working in the ER, that's one of the things that they look for pretty quickly when it comes to blood work. Calcium has a lot of roles that a lot of people aren't aware of. Calcium is not just for, building strong bones and things like that. Calcium is actually responsible for one of the electrolytes largely responsible for muscle firing or muscle contraction. So you need calcium for a lot of things outside of just your skeletal system. Your normal levels for this are going to be 8.6 to 10.2 milligrams per deciliter. And then again, hyper means high and low. When it comes to these, like hypocalcemia, there are chronic conditions where you can experience that. But obviously this can be acute as well. Hypocalcemia seems to be most common in like elderly women and has a lot to do with hormones and things like that. But again, you can experience these for a variety of reasons, especially if you're experiencing fluid loss. So these are some of the different areas where calcium actually plays a role. And it's, like I said, it's not just bones, but this is kind of what we've been taught about. And when it comes to the bones really are just kind of a house for the calcium in this case. And the bones will give your body calcium from the bone itself if it needs it. And you can see where that's problematic when it comes to people that have like absorption problems, or maybe people that have problems managing their electrolytes in general, or like diabetics, which we'll talk about in a little bit. Calcium is a buffer. So if you don't have anything else to help buffer your blood pH, your bones will give up calcium. And then, ideally it'll get more calcium back and rebuild those bone cells back. But if it doesn't, then it can become pathologic and you can develop things like osteoporosis. So calcium is very important for kidney function as well. And then as far as the small intestine goes, there are different parts of the intestine that absorb different nutrients. I couldn't honestly tell you where calcium gets absorbed specifically, but it takes place in the small intestine much of the time. And then you also have your thyroid, which hormones secreted by the thyroid are what encourage your bones to give that calcium if it needs it. So it's a communication device. Phosphates are one that I can't honestly say I've heard too much about. It is important when it comes to the buffer system as far as your blood pH. I don't recall the numbers and it doesn't list it on here, but it's, like I said, it's a buffer, and then you have your high and your low levels. Again, I haven't heard too much about it. It might be something more frequently discussed in the hospitals, but pre-hospital phosphates aren't really anything we talk about too much. Magnesium is a really common one, especially it's very popular in pop culture right now because it has so many applications. In this case, magnesium has a ton of roles that it fulfills within your body. And then the range for it is 1.6 to 2.6 milliequivalents per liter. That's also a rather small range. When it comes to magnesium pre-hospital, we're usually talking about giving it as a medication. When it comes to this slide, we're talking about the serum levels. So those are two different instances. Most of your magnesium is going to be stored in your bones, which is another thing that your bones are giving up if it needs to, calcium and magnesium, as well as phosphates, I believe. But 49%, so pretty much the other half of it is in your body's cells, and then 1% is in your extracellular fluid. So magnesium is a pretty busy molecule. It's fulfilling a lot of jobs, which is, from what I understand, why when we look at magnesium, we look at all the effects it has on all the different body systems. Why are we using it? What do the levels that they already have, could they be causing that? So on and so forth. Magnesium's involved in a lot of things. So I've talked about pH a lot in the last couple of slides. So just for a reminder of what pH is a measurement of hydrogen in gases, liquids, all that stuff. So pH, I believe it stands for per hydrogen or par hydrogen. It just has to do with the number of available hydrogen molecules. Hydrogen does make things acidic, similar to one of its friends, CO2, that we're pretty used to talking about. As the pH goes down, that means the acidity, or it is becoming more acidic. So the scale, 7.3 to 7.5 is where our blood tends to lie. That's pretty neutral in the middle there. If you go up to the 14, that is going to be your alkaline or basic or alkalotic, whatever you want to call it. And then below that 7.3, all the way down to 1 is going to be your acidic. So the further they are from that neutral 7, the more caustic they're going to be. An acid with a pH of 1 is incredibly caustic. An alkaline substance with a pH of 14 is incredibly caustic. So as you get closer to neutral, it becomes more tolerable. Naturally, that's where our bodies reside, because it's at a place where our tissues won't be damaged by that pH. If you do have a problem with your pH, it's going to cause a ton of problems with your electrolytes. Your electrolytes they have a ton of functions as far as muscle firing, cellular activity, so on and so forth. But they also play a really big role, like we just talked about, with magnesium and calcium as having very important roles as far as your electrolyte functioning, because they're electrolytes, but they're also fulfilling another job, such as a buffer in that case. That makes sense then if you think about it. Okay, well, you're having a problem with your calcium levels. Well, that's going to be a problem for your bones, but it's also going to be a problem for your metabolism because you need it. This is a really interesting picture. If you've never heard of the bicarb carbonic acid cycle, we're not going to go too crazy in depth into it, but you just have to kind of think about it like this. So bicarb or sodium bicarbonate, this actually has a higher pH because it is more basic, and then carbonic acid has a lower pH because it's an acid. So the carbonic acid has hydrogen more readily available. Now what's really cool about this, just for a quick rundown on how this works, is your carbonic acid, these two things, the sodium bicarbonate and carbonic acid, will come together with CO2 and water, and they're just breaking the two molecules down and creating other things, which is really cool. So if you need more carbonic acid, your body can just go cleave off certain molecules and you have that, because these two things come together and then disconnect so easily and rapidly, because that's their job, is to buffer. So it's with the bicarb, if you add it to something, you're going to make it more basic. If you add carbonic acid, you're going to make it more acidic. In this case, it's saying this person maybe has excessive carbonic acid, which means their pH is low, and the bicarbonate levels that they already have are not enough to buffer it. So the kidneys are going to encourage the excretion and delivery of bicarb, because it just needs a little bit more. And that's what this is showing with this lighter color on the top here. This is just the additional bicarb that the body is trying to give in. Because there's bicarb readily available, but it needs more. So then let's say, just to play off of this, that the bicarb actually, it kind of flips, and now the bicarb is the heavy side and the carbonic acid is the heavy side. Well, now your body's going to go through the process of creating more carbonic acid to balance that out. They work super closely together. The two of these things, again, they come together and dissociate super easily. That's a pretty simple rundown of your buffer system. So there are a couple of terms that you're going to hear regarding acid-base balances. There's going to be alkalosis and acidosis, and then before that there's going to be metabolic and respiratory. So you can have metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Those are the things that you'll hear about to start. So the first word that you see, whether it's respiratory or metabolic, is telling you what's causing the problem. So let's say someone has kidney problems and they're in kidney failure. Well, maybe they're unable to produce the bicarb that they need to because our pH is going down and we're becoming more acidic. So now we would be in a metabolic acidosis, because the problem is our kidneys, which are responsible for producing the buffer for our metabolism. So we are now in an acidic state. Our pH is down. So that's how that would work. Another good example is a respiratory alkalosis, and this is common in your anxiety patients. The cause is respiratory in nature. So their respiratory drive is up, and then because they're breathing so quickly, they're dropping their CO2 levels because they're breathing so much of that off so quickly that it actually puts their blood pH into a more basic state. So then they're in what we call a respiratory alkalosis because they're alkalotic and it's from a respiratory cause. Just depends. Again, sometimes you'll have numbers for these kinds of things. It's just more of a concept that I encourage students to be aware of. I used it quite frequently when I was working on the field and assessing patients, always considering those kinds of things. So there are there is a lot of processes that can cause cellular injury. Not everything is going to be completely destructive, but any type of cellular injury is not good. But obviously, if the cells can tolerate some degree, we like that. We don't want to have other cells replace them, or like scar tissue and whatnot if we don't have to. That being said, unfortunately, a lot of the times in these cases, these can be quite drastic. Hypoxia, obviously, that's going to cause damage to the tissues because they can't function without it. Ischemia, so hypoxia is a lack of oxygen. Ischemia is a lack of blood supply. It's important to distinguish between those two because when we talk about hypoxia, we're just talking about oxygen specifically. When we talk about ischemia, we're talking about blood flow, which implies adequate oxygen drop-off, adequate CO2 removal, waste removal, all of those things. That's ischemia. Chemical injury, infectious injury, those are pretty straightforward. Immunologic, think like anaphylaxis with that one. Physical damage, anytime you break your arm or something like that. Inflammatory injury could be something like swelling, severe swelling causing like compartment syndrome, all those kinds of things. This is, if you're into histology, this is a pretty cool picture. This shows two different tissue samples under a microscope. And what they're actually pointing out here is that these are the same type of tissue and same type of cells, but for whatever reason, it's kind of hard to see, but you can see the little striations on this picture on the left. That's where those cells come together. And it's called a sarcomere. That's how muscle cells come together to create muscle tissues. In this picture on the right, you can hardly see any of that, and you can see where there's this nuclear debris, meaning the tissue's been destroyed, and now what was on the inside in the nucleus, kind of like the brain of the cell, is now on the outside, which implies some pretty dramatic cellular destruction. I couldn't tell you why or what happened, but this picture on the right is a pretty disastrous looking picture of someone's tissue. So for hypoxic injury, hypoxic injuries are going to be the most common. We see them all the time. That's one of the number one things that we look out for, or that we try to, right? Unfortunately, there's only so much that we can recognize in people, but hypoxic injuries are always at the top of our list. Cells that are hypoxic, even if it's just for a couple of minutes, a couple of seconds, it's already irritating to them. Tissues don't last as long. Some people can sustain these without as much injury for longer. I think it's just kind of luck of the draw, honestly. But if you have extended hypoxic or an extended hypoxic event, it's the cell and tissues are unfortunately going to die off because oxygen, they need it for energy production, and if they don't have that, the tissue site's going to get progressively more irritated. What's also going to happen is that as those cells get irritated, they're going to release something called cell mediators. And cell mediators, while they are valuable, they're basically how cells communicate with each other. They unfortunately only almost kind of encourage destruction of tissues. And they're just trying to help. Think about things like histamines, prostaglandins, all of those. They are trying to help, but unfortunately they usually end up causing a little bit more damage because of the effects of what they actually do. Chemical injury would be anything with chemicals. Even the air that we breathe is a chemical, remember that, technically, I believe. But these things, again, I can't honestly say I've run into too many of these in the field, but it's always worth considering a hazmat exposure. If it is a hazmat exposure, you need to get the hazmat team involved, especially for some of these, like, cyanide and crazy stuff like that. Just be careful. They usually have those things kind of pointed out before you even get to the call. Infectious injury is really interesting to me because this is caused by any of those bugs that we always think about. Bacteria, viruses, fungi, probably even parasites in here. But it's because even though it's a bacteria cell, which is teeny tiny or even smaller as a virus, it might not make sense why or how these are so destructive. But when you consider how aggressive some of these viruses and bacteria are, and when, especially after they've established their colony, they can grow super rapidly and cause a ton of problems in a very short window. Just a reminder that bacterial infections are usually higher temperatures with a more rapid onset. Viruses are usually lower grade fevers with a slower onset. So when we refer to how destructive a pathogen is, we usually use the word virulence, and that just means, or viral, that might be a word that you've heard before. But that just basically implies that the bacteria or the virus in particular is pretty aggressive and has the ability to take over pretty quickly. Viruses in particular are a little scary because the way the viruses work is they embed themselves in the cell's DNA so that the cell replicates. And then once that cell replicates, the virus destroys the cell after it's reproduced. So it's a pretty destructive process. In fact, not all of them act like that, but that is the nature of viruses. They work specifically in their host's DNA. Bacteria are very destructive to tissue because of how rapid they grow and a host of other things. So if you have a patient who has a depressed immune system or maybe some kind of autoimmune disease, or they're on immunosuppressants or whatever, just please make sure you're keeping your ambulance clean for those kinds of people because their immune system is already down. And not just clean your ambulance, just be hygienic, but these people, even if they get exposure to a simple common cold virus, it can be pretty catastrophic for them. So this is a bacteria under a microscope, and what this is showing you, I don't honestly know what kind of bacteria this is, but this capsule on the outside, depending on what it's actually made of, when it comes to certain bacteria, they are actually very well protected because of this wall and how it's adapted to basically be impenetrable by our immune system. So what we have to basically do with these guys is rely on other cells, our white blood cells called phagocytes, to just come up and eat this because it has enzyme, or those cells have enzymes that break down those kinds of things. As they are right now, nothing probably would have an easy time penetrating this cell wall. But again, that's where the enzymes inside of those phagocytes come in. It's just another example of how bacteria evolved so quickly, is by having things like that outer cell wall that are so easy or so difficult to penetrate, requiring more heavy duty work with like your phagocytes, for example. So inflammation is interesting because I think we're all under the impression that inflammation is bad. It hurts. It's not good. It does hurt, but inflammation does have a purpose. With the swelling, the redness around it, the pain, all that's all going to come because it's injured. But what your body's actually trying to do is help. That's all your body's ever trying to do is help. That being said, inflammation can also be very destructive, especially if it's a chronic problem. Anybody that has like a chronic inflammatory disorder of some kind will tell you just how much or how difficult it can be because inflammation is very destructive, especially to joints. In this case, as far as the inflammatory injuries, we're not going to experience much of this in the pre-hospital system, but if you do go to work in like a hospital or something or move on to like nursing school, this is probably something that you'll interact with a lot more regarding things like medications and chronic wound care or chronic wound disease and stuff like that. So, signs of inflammation are going to be that heat that I was talking about, redness, tenderness, swelling, pain. Depending on where the inflammation is, if it's in like a certain joint or whatever, you might have decreased range of motion in that area as well. So this is just kind of explaining what I just did, but with like a visual representation. In this case, it's going off of a chemical agent. We'll just say, it's some, I don't know, farming chemical. We move down, it causes a tissue injury. In this case, we have the physical agent, pathogenic microorganism, and chemical agent that it's giving us as a possible cause. Regardless, we have the tissue injury. And then as we look at the different causes here, we can kind of pick out the things that we just talked about. So if we know that when the tissue gets injured, it releases these cell mediators like those histamines and prostaglandins and leukotrienes and stuff. Those are all going to cause or do different things. I couldn't honestly tell you which one is responsible definitely for each of these, but for example, the capillary dilation, if I remember correctly, is usually caused by histamines and prostaglandins. And that causes increased blood flow, which causes heat. Increased capillary permeability, which has to do with those capillary beds. They're already quite thin, but they can open up even more and allow more fluid to get out. That's what that's talking about, is that ability of those capillary beds to open up more. It's called increased permeability. And that can be a problem because there's fluid rushing to that site. It's helpful, your body is trying to be helpful by stabilizing the area, but then you get like the pain and the redness and the tenderness with it. So again, this is everything I already just chatted about, but just gives you an idea of why those things happen. So for injurious genetic factors, this is really interesting for us. We don't get to do anything with this aside from the information that we get from a patient who might have something like this. But really, when we're talking about genetic factors, we're talking about something that, you know, someone inherited. Maybe it's like a family thing they have multiple generations of. You know, maybe it's a chromosomal defect. There's a ton of things it could be with genetics. It's not always a tie to your family. Some people just have a mutation and it just shows up. The common ones that we see are like the genetic influences, or in this case, the slide is calling it a genetic factor. Some overall things that we think about, or at least that I would say I've had exposure to, would be like chromosomal disorders, atherosclerosis, obesity, cardiovascular disease, psychiatric conditions, which sounds weird to throw into damaged cells, but certain conditions actually are some of their characteristics are decreased brain mass, like we'll talk about here in a minute. But all of these, your genes play a significant role in how they are expressed. For example, my family has cardiovascular disease. It's a genetic thing that's been in our family forever. So in that case, yeah, that's a genetic influence for me, but also I could have been born with a mutation that gave me cardiovascular disease as well. So again, it could go both ways. As far as injurious nutritional balances, obesity, obviously, obesity is a really difficult thing for a ton of other conditions. So like diabetes with obesity, heart disease with obesity, it really adds a layer of complexity to those patients. And then on the flip side of that, you have your malnourished patients. This one's kind of interesting. At least I've seen really only a handful of people that were truly malnourished. And unfortunately, these are usually going to be in your neglected population. So always keep an eye out on that. But with the malnutrition, you're going to get the vitamin and mineral deficiencies. You're also going to get like inappropriate organ function, because if you don't have enough proteins or the right proteins, your liver can't work. Well, if you don't have enough of this, then your kidneys won't work. So this all cascades into a ton of other diseases. Injurious physical agents or conditions, heat, cold, radiation, just totally depends on how long the tissue has been exposed to that kind of physical agent. You could be talking about all kinds of things like frostbite, sunburn, which sunburn could be radiation and heat almost to an extent, but probably a little bit more of like heat stroke and things like that. As these progress, obviously you will have destruction of that tissue as you physically change it. And like I said, in this case, it's pretty easy to say heat, okay, like heat stroke. You could also argue sunburns. Cold would be like your trench foot, frostbite, but radiation, the thing about this that I find the most interesting is that radiation, while it does damage the cells, it causes permanent damage, and that's where we actually get a lot of skin cancers coming from. There's a lot of consistent radiation injury to your skin. So it doesn't necessarily kill it, it will alter it, the cells in that area sometimes. So that's a little bit of how like the cancer part works with radiation. Apoptosis is, if you haven't heard of this word before, it's honestly probably one of the more interesting things that our cells do. It is a cell behavior. And basically what happens is so your cells go through multiple checkpoints during its development. And it basically says like, okay, we're good here, good here, good here. And then let's say it's about to, get shuttled out to wherever in the body. It'll go through its final check, let's say, and something's wrong with it. So it's going to recognize something's wrong with it. Maybe it has a mutation. Maybe it has damage to its cell membrane, whatever. It will basically get to the point of where the cell engorges so severely that it bursts and the cell just ruptures and it dies. It does have a job. And again, back to the cancer things, there's the thought that, that process, apoptosis, is intended to help prevent things like cancer growth. Obviously, cancer is pretty prolific, but apoptosis as it is really just your body going through cellular checks to make sure that the cells that it's producing aren't cancerous or going to cause problems for other tissues. When the cell is destroyed like that, the little pieces that come out of it just get picked up by other cells, which is also really nice because it's recycling. So, reduce, reuse, recycle of all the things that were inside of that cell, which does help in that area as well. This is just kind of everything, again, I talked about visual representation of it. This is just showing a normal cell here that's been exposed to something up here, virus, bacteria, whatever, converting it into an abnormal cell. And there's a couple of things that can happen with these abnormal cells. We like to think that our body would recognize it much more quickly than it does, but that's not always the case because with like viruses, for example, your body doesn't do self-checks on every single cell's nuclei, which is where the virus resides. So it's easy to understand why viruses can get away with it so easily versus like bacteria, for example, which are much larger than viruses. So in this case, maybe the cell was able to reach this abnormal shape because the immune system was ineffective. And in general, the immune system clearly was ineffective in just this case, not in general, but just this case with this cell, which happens. And so the cell is going to kind of have to make a decision based off its condition. So if the cell doesn't go through apoptosis, it runs the risk of becoming cancerous. If it does go through apoptosis, then you just have destruction of that cell. That being said, you are losing a soldier, if you want to think about it like that in this case. So that's also not desired, but I'd say it's probably a little more so than, for example, the cancer part of it that it could be. When a cell reaches the point of a tissue reaches the actual point of dying, we call that necrosis. So there's a couple of words that you're going to hear a lot of. There's like ischemia, infarction, and necrosis. Ischemia is that decreased blood flow, right? Necrosis is really where the tissue dies. And infarction is when there's permanent damage to that area. Necrosis, you've probably heard of it referring to certain bacterial infections. Totally depends. Just if someone has necrotic tissue, it is best that it gets removed because it is dead tissue. And that can cause an infection as well. And that's usually, like I said, with pretty serious cases. I've seen necrosis on some people before, and they were oftentimes linked to like skin lesions and things like that. So this last little bit is about shock. It's just a refresh. So if you remember, shock is a state of hypoperfusion. If we are perfusing appropriately, we have adequate oxygen delivery by means of red blood cells. We have CO2 removal, sugar drop-off, all of that stuff. And not just that, but also the ability to make it back up to your lungs to breathe in the oxygen and expire the CO2. So there's a lot of levels to it, right? Anytime you have a problem with one of these things, the pump, the pipes, or the blood, that's where shock comes in. And the problem with shock is that it's a problem with a lot of things, but shock in particular always results in death if it's not treated appropriately. Treated and acknowledged rapidly enough. You've got two big types of shock in the big categories. You've got your central and peripheral. So your central shock is going to be your cardiogenic and obstructive. I just think about that because both of these are taking place in your core, which is usually another word for that is central core. And then you've got your distributive, which we'll go over here in just a second. So this is cardiac tamponade. This picture is kind of crazy. I don't know how they got it to be that blue. But basically what this is trying to show you is this is what it looked like. The picture on the left here is what it looked like. I'm assuming this is on autopsy, but as they cut away the chest. And then this picture on the right is after they cut through that pericardial sac and we're actually able to visualize the heart muscle. Right here, there is a pretty massive blood clot. If you actually get to zoom in on the picture, you can see it, but that's what cardiac tamponade is. For whatever reason, there is blood in between the heart muscle and the pericardial sac. Makes sense why your cardiac output will go down substantially if it can't beat effectively. If it's getting squished, it's not going to be able to contract or relax like it needs to. And that's why we see hypotension with one of the reasons that we see hypotension with cardiac tamponade. The treatment for that is only done in the hospital. So you'll just need to drive fast. This is an aneurysm. These are really, really scary. Totally depends on where they are, which blood vessel. There are people who know that they have them, and they live very normal lives. But these are very scary because with these, you have this large aneurysm. In this case, this is the descending aorta, which is massive. That's a very large artery. And you have a ton of blood supply already going to that area because it's the aorta. Now you factor in that you have an additional X amount of blood volume surrounding that area, and it's only going to get more full. So when that happens, it gets too full, it ruptures. And again, it totally depends on where it is. It can be anywhere throughout the length of your aorta from, your top of your neck all the way down to your pelvis, but it could be anywhere in there. It's just, in this case, this was showing, I would venture to guess, the aortic arch with the 3 branches here. And then this would probably be more in the area of like your stomach. So hypovolemic shock, there are 2 types of that. You have hemorrhagic and non-hemorrhagic. So non-hemorrhagic is when, let's say, like you're dehydrated, people who get sick, like they get the flu or whatever, and they're not hydrated appropriately. That's your non-hemorrhagic. Hemorrhagic is going to be people that are bleeding, obviously. So hypovolemic shock is a type of distributive shock. And with distributive shock, the overarching idea of it is that you have widespread vasodilation, which decreases the resistance inside of your blood vessels and the overall capacity of those blood vessels to carry the blood volume. And with distributive shock, another thing that you might hear, a term people say, I've heard it a couple of times, some people refer to these 3, the anaphylactic, septic, and neurogenic, as hot shock or red shock, because these people present very, very red initially, versus a lot of your other patients, which will go from having normal skin color to pale, cool, diaphoretic. These guys will go from normal skin color to being like bright red or flushed and sweaty. So you might hear that. It doesn't really change anything. It's just a term. But these 3, I will say that is a unique thing that I've experienced between these 3, is that the patients are typically like bright red and they're super flushed and sweaty. Anaphylaxis is an allergic reaction. We just kind of went through some of the process for that a little bit ago on one of the slides where it talks about like vasodilation and all that. Just think about all of those things happening but getting worse. And obviously there are other signs that you might see, but when it comes to your ABCs with anaphylaxis, those are the not uncommon for us to get stuck on our ABCs and anaphylaxis. There's a lot of levels to these. They are heart patients as well as blood vessel patients, as well as blood volume patients, and airway patients. They've got it all. So they can be very complex. Sepsis is widespread infection. Sepsis is a really difficult thing to get a clear answer on in the medical community. Everyone seems to kind of have different opinions on it. You might work in a system where they have a sepsis protocol. You might not. For us, we don't have one, as far as, at least here locally, that I'm aware of. But as far as sepsis goes, really these people have some kind of infection that they've just been sitting with for a little bit, and now it's gone from being a local infection to being a systemic infection. Septic patients can be really, really sick. Don't be surprised if They have a really high fever, and just their skin turgor is terrible when you get there. They're almost always hypovolemic as well. And then neurogenic is a result from a spinal cord injury. In this case, you lose your sympathetic tone when you damage that spinal cord, which allows your parasympathetic nervous system to take over. And so it's not as common. I can't honestly say I've seen too many of these, but that is just something to be aware of. With these as well, every shock patient needs to be kept warm, but especially these guys, because the spinal cord injuries, because depending on the spinal cord injury, the grade of it, and then where it is, the patient might not be able to shiver. So that's a very important thing. But again, just to remind, the shock treatment is supine positioning or Trendelenburg's. I personally like supine. Trendelenburg's is quickly losing favor. High flow oxygen. For checkoffs, I usually encourage my students to do a non-rebreather at high flow for just to kind of get that point out of the way. They need high flow anyways for shock treatment. Keep them warm, cover them with blankets, cover them up, crank up the heat in your ambulance, all that kind of stuff. That's about it for this. For the advanced, when you do get to the point of giving IV or giving IV fluids, you can also consider it for these people as well, but that'll be addressed in another lecture. So some of the management of shock that is nothing new compared to what you probably learned in EMT school. So the equation, cardiac output equals heart rate times stroke volume. It's the same thing. It's a really great equation. It's you don't have to have the numbers for it, but it is really valuable to understand it as a concept. So cardiac output equals heart rate times stroke volume. So you have heart rate, which is the rapidity, and then you have your stroke volume, which is the volume. So if you have decreased heart rate, well, your volume, it's kind of hard to make your volume go up, right? You can't just go and drink a bunch of water and then immediately have your volume go up. So that's going to be a problem. Well, let's say your stroke volume is high because you're having a stroke and your blood pressure is high. That's really what stroke volume is talking about. Your blood pressure is high. Well, one of the compensatory mechanisms that we see is bradycardia, because our stroke volume is high, but our heart rate can be low to kind of maybe find an even ground for cardiac output. That's the overall concept of it. The rapid heartbeat is something that you will see usually at the beginning. Really, when someone starts decompensating, you use blood pressure as the gauge for that. So shock, again, always results in death if it's not treated. But right before death, they're going to experience this. This is multiple organ dysfunction syndrome. And this is very common in people that also have massive, major traumatic events like, traumatic injuries kind of. It can be, your septic patients, it's anybody really. But it just depends on the patient's condition as to which organ systems are going to fail. Much of the time, it's going to be kidneys and heart failure and liver failure. But again, it really could be anything. There's your primary and your secondary MODS. That's the abbreviation for it. It's pretty much just how it sounds. The primary is what's happening at the beginning, and then secondary is what happens after that, like after the process has taken place. And I should say the whole point of this MODS is to it's trying to essentially kind of shut off the part or certain organs that aren't as important and direct the blood flow to the ones that are more important. And a lot of people have heard that before and think of the word shunting, but this is much more aggressive than that. So we've already chatted about the immune system, but just for a little review, it is our self-defense. Your skin is the largest organ in your body and does a lot of really good things for you as far as your immune system goes. It's a literal and figurative barrier too. So very difficult for things to get introduced into our body because of our skin, outside of things like cuts and scrapes and whatnot. That's just how good it is. But another thing I just want to add into here too is PPE. That's another thing thing to add with immunology is making sure you're wearing your PPE, not just for you, but for your patients, because having those barriers, those literal barriers, is really important for disease and infection prevention. So you have two types of immunity. You have your natural immunity and your acquired immunity. Natural is what you just have with you. You get some of that through your mom, and then just the development of a human, like what you get with the immune system with that. we're all going to have, our white blood cells and all that. But then we develop things like acquired immunity, which is where we get like our killer T cells that attack certain things. So when you're born, you have your natural immunity that is going to help with like the big picture viruses and bacteria, but then your acquired immunity is what you get as you get older and get exposed to more things, making you less likely to succumb to severe infection and disease and things like that. So anything that gains or garners an immune response from the body is an immunogen. I can't say that right. Immunogen. And then you'll also hear the word antigen. Antigen is anything that enters the body that does not belong in the body. Specifically, though, underneath of that, if it evokes an immune response, it's called an immunogen. So this is what I was talking about with the some of the things that you develop with your acquired immunity, like your antibodies. You have these two together at the top, antigen and antibody. And the reason for that is because antibodies are actually specifically made to recognize certain antigens. And that's the whole concept behind vaccines. So when an antibody binds with an antigen, it creates something called an antigen-antibody complex. Excuse me. And what this does is this causes a few different things. It's sort of a cascade of events. Once that complex gets created, it activates the complement system, which is a system that has to do with blood clotting and is very, very complex. And it also encourages agglutination, which is, it encourages all of those, let's say bacteria or viruses or whatever that are bound up with an antibody. They're going to come together and as a group and stay that way, so they're more easily removed. Now, what's also going to happen because of the agglutination is precipitation and neutralization. Neutralization is like I was talking about earlier, when you have those phagocytes that have the enzymes that literally they just go up and swallow the antigen, whatever virus or whatever, and then they break it down that way. So that's a very common practice. The cells are called phagocytes, and it makes sense if you think about it, because they're literally just going up and eating, like Pac-Man almost, but they're eating the bacteria or whatever it is. So with those things, all three of these on this side, what's going to encourage those is that phagocytosis, like I was just talking about with those phagocytes. And then on the other side, since the complement system has been activated, you're going to have a reaction from those immune cells that, again, encourages phagocytosis but encourages inflammation. And that's where the complement system comes in with inflammation, is that it actually encourages the release of prostaglandins. Eventually, what we want to happen is it's going to bind up with it's going to create an antigen-antibody complex, and then it's going to destroy it, or I guess it'll get destroyed by the cells, the white blood cells, but ideally, the cell will be destroyed before it gets to that point. At this point, it's just kind of cleanup duty. Once the cells are destroyed, getting them cleaned up in all of their contents, because you don't want bacteria and viral contents floating around in your bloodstream. Humoral immunity is very interesting as well. Humoral immunity is kind of in its own thing, and this is specifically the branch of your immune system that is responsible for recognition of those antigens that I just talked about. So those antibodies and then those cell mediators, basically what they do, it's memory. So your immune system has memory, and that's what your humoral is involved in, is that side of it, where it says, okay, let's say we fought off the flu virus last year, COVID last year. Okay, well, we know this, we recognize it because last time we had an immune response to it. Our white blood cells, specifically the T lymphocytes, or the killer T cells that we all know and love, they recognize it and they're actually able to treat it more quickly because it's already been exposed to it and the antibodies have been created. So as long as the antibody is created, that means that your body has recognized that antigen in particular and has a plan for how to handle it. We're not going to go through this. This is a pretty complex picture. It just talks about basically the programming of your memory cells in your immune system. So the T cells basically report back to the memory cells, the B cells, and tell them kind of give them the skinny on that bacteria, and then the memory cells go through their own process of how do we recall this? We need to produce the antibodies for it, and then that's what they do. They make the antibodies. This is also just a really cool picture. It just kind of shows you how these different white blood cells interact with each other. So for example, this is showing a macrophage. A macrophage is a very large cell, white blood cell. Macro means large, and then phage means eat. So it's a very large cell that gobbles up those antigens like I was talking about earlier. Once that macrophage actually processes that antigen, it's going to go interact with the T lymphocyte and the B lymphocytes. These two are going to interact together, and they're going to create memory cells. So you have to have the B and T lymphocytes to create the memory cells. Now, in this case, the B lymphocytes are going to go out or off to this side, and they're going to be more involved with the humoral immunity, which is, again, that memory or like the antibodies part of it. And then you have the activated T lymphocyte, which is basically the killer T cells putting on its helmet at this point and is getting ready to take off for battle. That's what it means when it says activated. So it does branch out. It all starts off with this macrophage basically talking to other cells saying, hey, this is what I found, and then reporting it to its supervisor. This is essentially what's happening there. So again, not too much to get into this, but just so that you're aware of what's going on in this picture, this is showing an immunoglobulin. I can't say that word, globulin. And basically what these antibodies, again, are created specifically out of that memory because, like this antigen right here, it's a perfect fit for this variable region on this antibody. So this is the immunoglobulin G, or IgG is something that you'll hear. So let's say IgG, this is COVID right here, the COVID virus. When this virus links up with this variable region, it's going to activate this antibody, and that antibody is going to go tattle and tell all of its other neighboring cells that something is wrong, and that it is now activated, and that there is a threat. Because if it's not, like, let's say that was like the common cold virus, well, it might kind of fit in here, but it might be off. That's the point of this being memory-based, is that this antibody was specifically made for this antigen, and it will only be activated by that antigen or something that's pretty darn close to it. So, as far as the inflammatory response goes, we've already talked about a lot of this. It totally just depends on the degree of injury, like the nature of the injury, how long it's been going on for, all of those things. And it involves pretty much everything in the area that it's starting off in. We're talking soft tissue, you could have bone involvement, but blood vessel, nerve, all of that stuff. Inflammation doesn't discriminate against tissue sites, at least that I've seen. So for this next slide of the inflammatory response, just really quick, these neutrophils here, these are a type of white blood cell. I don't remember what they are specifically for, but there are white blood cells that specifically go for viruses, some go for bacteria. I just don't quite remember what neutrophils go for. But basically what this whole slide is saying is that this is just another part of it, is that when these cells arrive, these neutrophils, there's a lot of stuff that starts going on because those neutrophils are being deployed to that area to do their job. So there's all kinds of processes that get kicked off. Those cell mediators, like I talked about, are down. Some of those are down here. Your cytokines, interleukins. Yeah, so this is all basically just saying a ton of stuff is happening in that area, and even more things once those neutrophils arrive and basically say, yeah, there is a problem here, they're going to recruit even more things, like those other white blood cells and increase fluid and whatnot. So normal wound healing involves repair of damaged tissue, removal of inflammatory debris, restoration of tissues to a normal state, and regeneration of cells. you can appreciate where really anything can go wrong in those stages. Even if you just get like a simple little, maybe minor infection of a small laceration, it can totally get infected. Thankfully, much of the time, though, our bodies do this without any difficulty. But if you think back to those things that I was talking about at the beginning of the lecture, again, with like how things like cancer come up, you can look at this and be like, oh, well, I can appreciate where that comes in. There's a lot of things going on that involve healing. Well, if something doesn't heal right, then, what's the cause of it? Is it just an abnormal growth, or is it, say, like cancerous? All of these things, there are so many things that can be happening at all of these levels. It's quite miraculous that it doesn't happen more often. Again, though, that is where apoptosis comes in if it has to. Sometimes this normal wound care does have to take place by means of another person, such as like a wound care nurse or physician. Those are for your particularly nasty cases, and I say nasty as in like they're the infection or maybe the wound or something like that is not healing well, or maybe isn't responding to the treatments well. That's what I mean by nasty. They can become pretty problematic pretty quickly. And then obviously if it becomes systemic, it leads into a septic infection. Sepsis is quite nasty. Again, like I said before, really it's pretty polarized. It seems to be a pretty polarizing topic in the medical community, but in general, your septic patients are going to be warm, usually pretty altered, and then, tachycardic, hypotensive, all that stuff. We see a lot of them. This is, again, just a flow chart. It's kind of showing you the overall process for it with the pain and the swelling and the redness like we already talked about. This just puts all of it together. So for hypersensitivity reactions, we're thinking anaphylaxis or allergic reaction. It is a scale. Not everyone who has an allergic reaction to something is going to have airway involvement. And sometimes people have never had an allergic reaction to that before, and then they just spontaneously develop one. The hypersensitivity reactions are intimidating for that reason. They are very unpredictable and they're very dynamic. Like I said earlier, with these patients, there's a lot of potential for pump problems with the heart, blood volume, blood vessel dysfunction, and airway. Most people that you talk to that have worked in 911 will tell you these patients can be kind of scary. But there are different types. Excuse me. And this is not something we're going to be doing in the field. Again, it's just a good thing for you to be aware of. The different types have to do with different stages as far as like the process of going towards tissue death or necrosis or even infarction. There is a process for it. Again, your body is trying to stop this wherever it can, but as it progresses, it moves. They have this grading system for it with these different types, because that also gives you an idea of the outcomes for that patient. So type 1s are your immediate hypersensitivity reactions. These are the types where you experience it immediately. For me, for example, I'm allergic to adhesives. So if I put a piece of tape on my skin, I pretty much immediately start feeling the irritation. Type 2 would be your cytotoxic hypersensitivities. I'm not totally sure if this fits in that category, but the stuff with like chemicals kind of comes to my mind, like hair chemicals as well and things like that. I can see, because cytotoxic means it's toxic to cells. I can see where for some people that are allergic to like hair dyes and makeup and stuff might have that. The third type is tissue injury caused by immune complexes, which we already talked about. Unfortunately, the process of stopping an invader is a little destructive. Someone told me once upon a time that your immune system is kind of like superheroes. They always end up saving the day usually, but there's a pretty serious path of destruction afterwards. It's kind of what your immune reaction's doing in this case. Because those immune complexes can be kind of problematic. So in your type 4, you have your delayed or cell-mediated hypersensitivity. This is pretty common in your food allergies. Just because it's delayed or it's called delayed doesn't mean, we're talking hours. Typically, people present with symptoms within a couple of minutes. Delayed could just mean they experience it 30 to 45 minutes later. So just remember, just because the reaction isn't happening immediately and it's technically a delayed reaction doesn't mean it's actually going to be very, very delayed. It's just delayed from that couple of minutes that we're used to seeing. Excuse me. This is the process for a type 1 reaction if you'd like to look at it. It is kind of complex. But it does go a little bit more in depth into how certain antibodies, the like IgG and IgE, like we talked about, how those actually affect the tissue sites in the cells. So some more variances that you might see, excuse me, autoimmune reactions. So autoimmune diseases and the reason I bring this up right now is because a lot of people don't realize that autoimmune diseases are really your immune system attacking its own body. And so that's already their baseline. And then let's say these people get an infection and that ramps up their immune system even more. That can be really problematic for them. And then that also ties into this immunodeficiency, because some people that aren't taking those immunosuppressants, like a lot of autoimmune patients do, well, their immune system is probably going to be kind of crummy because they just can't, excuse me, their body can't fight anything, especially in this case with like your chemo patients as well. So anyone that has a lower functioning immune system is going to be immunodeficient. Now for this top point, the immune system targets different molecules depending on hypersensitivity reaction. All this is saying is just the variability. You could be allergic to really anything. There's anything out there, just for whatever reason your body decides it just doesn't like peanuts or it doesn't like bee venom or whatever. I wish I knew more about it, but it's just a grandiose overreaction to something that enters your body. It could be anything. So coming in towards the end of this PowerPoint, some factors that cause disease. A lot of this we've already talked about, but genetic factors, you could go think, like genetic diseases like hemophilia, for example. Environmental factors, you could go back to the trench foot and like frostbite, like we were talking about. Age-related factors, it's really anything to do with, if you're an elderly person, you're more susceptible to heart attacks. If you're a 2-year-old, you're more susceptible to croup, those kinds of things. And then sex-associated factors has to do with your particular sex, as far as like there are diseases particular to females and diseases particular to males and things like that. So this is probably nothing new. Uncontrollable versus controllable risk factors. Typically, we usually talk about cardiovascular disease with these, but again, it pertains to pretty much everything. Cardiovascular disease is just involved in everything, and this is heavily affected by these things. So the uncontrollable factors are things that you have no obviously control over. Genetics and race, like for example, people of color have higher clotting incidences than like, for example, Caucasians. Genetics, it could be, again, that like my family, we have cardiovascular disease. Those things are outside of our control. And then you've got your controllable factors like smoking, drinking, not eating well, not exercising, chronic unmanaged stress, all of those things. They're considered controllable because technically we can do something about them. Doesn't necessarily mean that they are as easy to control, for example, if that makes sense. Analysis of disease risk is a really interesting thing that EMS has actually kind of been getting involved in for the last couple of years with things like the community paramedic programs. There are other programs with like mobile health, mobile crisis, things like that. And this is what their focus is on. And there are actually a lot of social workers in the hospital that try to do things with this too. So basically what they do is they do a risk assessment of a patient and their family history, their personal history, and they say like, okay, so here are things that we're worried about with you, your risk factors. Here are some things that we can help you with to help maybe eliminate or significantly decrease these factors. So this part, the sociological part of it, is getting pretty big, or has gotten pretty big in the last couple of years, and is really, really helpful, especially if you're talking about like low income areas and stuff like that, where disease risk is substantially higher than others. And the last little bit is going to be some common familial diseases. Again, those genetic disorders that we were talking about. For example, I use my family a lot because we are a shining example of this. Many of us have a bee allergy, pretty severe bee allergy. There's the cardiovascular disease. It's a very common grouping in my family in particular. The word that they use is a familial tendency cluster, and I think that's actually a really great word for it because it sticks with families, right? A good example of this would be like the Tsar family over in Russia, which we'll talk about here in a second. So this picture, again, just another immune reaction, nothing too crazy. But cancer, there are certain types of cancers that do run in families, like breast cancer is what this is showing. Obviously, any really cancer, some are more rare than others, but they do have a tendency to run in families. Diabetes, also super common one. I know a lot of people, I have a friend of mine who has a couple siblings, and all of the kids got diabetes type 1 when they were little kids. So something you'll see a lot. With hemophilia, what's interesting, I mentioned the Tsar family of Russia just a minute ago. They had hemophilia in their family, which ultimately led to their demise because the family was inbreeding with each other. So siblings were having kids with siblings, and because hemophilia is a genetic disorder, they were getting influences from both sides. So hemophilia, as it is, if I understand correctly, is pretty particular to men. There are female types of hemophilia, but hemophilia as it is pretty specific to men. This chart on the right just kind of gives you an idea of how iron plays in, because iron is frequently one of the problems with blood disorders. You know, we're talking anemia, hemochromatosis over there is excessive iron. So iron is just what our red blood cells use so that we can bind up hemoglobin and oxygen and all that with the red blood cell. Some cardiovascular disease, you've got cardiomyopathies, which if you remember when I was talking about hypertrophies, like left ventricular hypertrophy, that is what considered a cardiomyopathy. So cardio means heart, my means muscle, and then path means disease. So it's a study of disease process for heart muscle. Mitral valve prolapse is when your mitral valve prolapses essentially and it doesn't close all the way, which can cause pressure problems in your heart. Coronary artery disease, hypertension, stroke, all of those things are pretty straightforward. Oh, sorry, this is just showing right here how this part of the left ventricle actually has hypertrophy and how it's causing problems with blood flow beneath of this valve. Another just quick thing I want to bring up is if this is actually what's happening, my big concern is if the blood's pooling in there. If it is, are there clots there? Oh my gosh, this is a kidney stone. As far as kidney stones go, there are different types. They're made of different things, different shapes. We see them a lot. They're most common in men, especially younger men, and people who consume particularly, I guess things like energy drinks, soda, tons of stuff like that, coffee. But gout is something else you can develop. Gout is really painful from what I hear. It's a collection, again, depending on the type of gout, it's a collection of whatever that is made out of being deposited in your joints. So the joints get really large and inflamed and they can almost kind of lock up. It's really painful. Both of these are under the renal disorders because they have to do with kidney function. Obviously with gout, the kidneys are having a problem managing certain compounds, I guess we'll say, versus kidney stones, it's that you have this really large stone that accumulated in your kidney and is now causing kidney failure or kidney dysfunction. Some GI disorders, we already talked about a few of these, but malabsorption disorders would be anybody that has a problem absorbing nutrients through their small intestine. That's where the majority of nutrient absorption takes place. I believe it's in the jejunum. But the malabsorption just means that, let's say that area isn't as good at absorbing things, so that person might have lower levels of that mineral or that nutrient because your small intestine is not absorbing it. Lactose intolerance, I'm lactose intolerant. It just means I can't eat dairy. I don't produce the enzyme for it. Generally speaking, very, very, very benign. Ulcerative colitis is a pretty difficult one. This is an autoimmune disease where people develop ulcers inside of their colon. It's very painful and frequently results in your colostomies. Crohn's disease is sort of similar to these malabsorption disorders. The area in your small intestine, those structures that help actually absorb things, in people with Crohn's disease, those get destroyed. So if they're destroyed, they can't absorb nutrients either. So those two are very closely tied. Peptic ulcer disease is recurrent ulcers. Gallstones, this is also something I've heard a lot in families as well. And then obesity, obviously, is something that's pretty prevalent just in our country right now anyways. Some neuromuscular disorders. Huntington's disease is a really aggressive neurological disorder. A lot of these, you'll find the common theme of like abnormal movements, difficulty speaking, difficulty swallowing, memory issues. A lot of those symptoms tie into all these. Muscular dystrophy is a muscle disease that usually results in the muscle cells slowly being broken down. So they look very similar to your atrophy patients. MS is a neurological disorder caused by, I believe the word is demyelination of the myelin sheaths. And then Alzheimer's, which again is a memory and cognitive disorder. Some other things that a lot of people don't think about are psychiatric disorders. If you remember from your EMT lectures, I'm sure you'll recall that there are the organic and functional disorders. So schizophrenia and bipolar disorder are thrown in here because they are, people with these have anatomically unique brains. It's not just a functional disorder like many of the other psychiatric conditions we think about. These ones actually have a lot to do with neuroanatomy. So that's why they're on here. And then you have stress. This is, if you did EMT school with the AAOS book, this is the exact same slide that it uses in the workforce safety chapter. And it's very important because it talks about stress in the setting for us as 911 providers, but also what it does on the physiologic level, because stress is very, very stressful on our body and hard on it. So the process for it, general adaptation syndrome is a really common phrase, and some people refer to that as alarm fatigue or burnout. It's all basically just saying that as you are exposed to a stimulus for an extended period of time, your body eventually stops recognizing it. And that's called desensitization. And that it ends up just getting to the point of exhaustion because you're just constantly getting constantly getting stimulated to the point of no longer actually recognizing the stimulus. That's general adaptation syndrome. Then that's problematic, not just for our brain and our emotional well-being, but because it affects everything else. And when I say that, I mean chronic stress levels cause chronic high stress hormone levels. So cortisol, and there's other like blood pressure specific hormones that can increase your blood pressure and things like that. So all of this ties in super closely together. Stress can do so many different things. It can kick off diseases. It can make it worse. But as a rule of thumb in my mind, I kind of look at stress the way I look at inflammation. It's a chronic problem and it has to be managed. Otherwise, it's going to continue and then it's going to cause destruction in the end. And those two I already talked about. So as far as the long-term effects of chronic stress, this right here, the hypothalamic pituitary adrenal axis, this is basically saying so your hypothalamus, your pituitary glands, and your adrenal glands, the way that those come together, they come together to manage stress symptoms. If they don't have that system regulated, you're going to have chronic stress, like elevated levels of stress, because all of those are involved with either hormone production or brain function. So, for example, the hypothalamus, that has to do with like blood pressure management, sleep, things like that. Well, if your hypothalamus is off kilter because of chronic stress, you can see presentation of symptoms like that, like insomnia and high blood pressure and whatnot. Obviously, if you are continuously exposed to this stress, like we said with the general adaptation syndrome, it's just going to lead to fatigue and burnout and all that. But the other thing is that when you have chronic like negative emotions, you have to think about how that's going to affect things systemically as well. So it might seem odd that it's in this presentation, but stress is a huge factor and it affects a lot of things. So, all right, that was chapter 8, Pathophysiology. I hope you learned a lot of things on here and maybe got a little bit of a refresher for some of your EMT stuff. So thanks for watching. Have a good day.